in the past year. First, I would like to invite Dr. Chitaranjan Mishra. He will be presenting on posterior assisted levitation using vacuum of vitrector for dropped nucleus. Dr. Chitaranjan is the head of Department of Retina Services, Research and Academics at Trilochan Nethralaya, Sambalpur. May I also invite Dr. Avnish to join me on the panel,
yes.
please.
So, should I start? Slides, please. Thank you, AIOS. Thank you, Dr. Devakant and all my friends. So, my talk is on vacuum-assisted levitation of the posteriorly dislocated cataractus lens. All of us know that posteriorly dislocated cataract lens can be of traumatic or iatrogenic etiology, and it needs a pars-plana vitrectomy with utmost retinal safety. The traditionally described method is pars-plana vitrectomy plus pars-plana lensectomy, and it needs a fragmatum and perfluorocarbon liquid. However, we describe a technique in which the levitation is done and we don't need fragmatum and PFCL. This is a video we can see over here. This technique I have named as vacuum assisted levitation. So here we can see there is a traumatic subluxated cataract. While attempted removal, there was a drop of the entire cataract with the nucleus, we can see. However, imagine a situation where in a resource scarce position you don't have access to fragmentum, so that is like going for fishing without having a fish net, isn't it? So what I am doing as a surgeon over there, I am doing a very good core vitrectomy, and PVD is not induced. I will emphasize on this statement why I have told that PVD is not induced, because do a very good core vitrectomy and base dissection. We can see over here we are doing base dissection. All of us know that core vitrectomy and base dissection are very vital for any vitreous surgery. Then this is a traditional sclerocorneal tunnel that all of us know from the SICS, manual small incision cataract surgery time. So this is just like a SICS tunnel. Then why I have shown this video, just like the eagle is lifting the fish, similarly you have to go below with the vacuum of the vitrector, maximum set 600, 650, whatever is there, lift it, bring up and hold it with the vacuum only. It dropped once, but here comes why I have not induced the PVD, because that vitreous sheet acts as a cushion over there. Then in the second attempt I am successful over here, and I am holding it in the pupillary plane without injuring the iris, insert the wire vectis, and it's just like SICS, the nucleus extraction. Of course, visco was used for the endothelial protection and with utmost respect to the iris tissue. It's just like extraction of the nucleus, what we do in SICS. Then I did a scleral fixated IOL. I do a modified Gabber's technique, no glue, no suture technique. So these are the four vital steps you can see in figure A, that is engaging the nucleus and levitating it up. Then in B you can see that is at the pupillary plane. I am holding it over there. And in C you can see extraction is done, and at D you can see the nucleus is completely out. So just to discuss, it's not, I am not telling it's a new very path-breaking innovation or something. Agrawal et al., they have demonstrated a phaco tip assisted levitation of dropped nucleus in these kind of situations. Kang et al., they have performed a visco trap technique. So our technique is basically a combination and some addition of existing things, what we can tell as a jugaad or something, but may not be fitting to entirely a kind of innovation thing. So what are the advantages? It obviates the need for fragmentum and PFCL, which is sometimes possible in a resource scarce area, especially where I am working in a very remote part of Odisha. There we can do with this technique without the need of fragmentum and PFCL. And what are the disadvantages? Possible damage to the corneal endothelium, iris and macula. There is this possibility there which we have to take care of. And difficult for large nucleus and small people. Small people cases I have tried, it's very difficult, and large nucleus also it's difficult. 25 gauge vitrectomy we cannot do, because 23 there is a large bore, so it is little easier over there. And initially I was thinking that if the capsule is intact only, we can hold it and take it out. However, what I have seen, even if the capsule is not intact, still with some nibbling we can create some kind of uh, uneven surface over the nucleus, and still we can lift it. I have other videos I can show in some some in the future presentations. So what are the learning points? In resource scarce scenarios, the management of a posteriorly dislocated cataract lens can be done without the need of fragmentome and PFCL liquid, and without the induction of PVD, the remaining seat of the posterior vitreous cortex, it actually acts as a cushion. So the need of PFCL for the protection of the macula is not there. So PFCL, without PFCL we can do this. And this seat actually protects from the possible mechanical trauma due to the fall of the cataract over the macula. And the vacuum of the vitrector can be used to levitate the posteriorly dropped nucleus, and further it is extracted out just like manual SICS. To summarize, vacuum assisted levitation technique is useful in resource scarce situations, in well dilated pupil, and a small cataract nucleus with intact capsule is better. However, without intact capsule also we can do this. However, I must tell that it's not a substitute plus PPV plus PPL, plasma vitrectomy plus plasma lensectomy, still stands the time tested technique for a dropped cataract lens. Thank you for your kind attention.
Thank you so much, Dr. Chitaranjan, for such a nice presentation. So, have you ever tried using your phaco probe without a sleeve? That has been also described for lensectomy.
Yes, that I agree. That's why in the discussion I have mentioned this. But because I am a posterior segment surgeon, like mostly my presentation was on the this thing vitrector. So that one I have not tried.
Okay.
But yes, people have done it and they have described. My, my
So you go and turn off the pulse mode, and if you turn off the pulse mode, then there will be less vibrations and there will be less spurting of the fluids, which generally flowing in the air and secreting onto that visualization system. And so you turn it off and you use the turn off the pulse or burst mode, whatever you are using, and then that would be better. And sometimes there is an issue with the Otley tips, which have the flare tip. So Otley tips have a flare tip. So then the entry is bigger than the this. So that we can create a lot of, and that is why this phacofragmentomes. And sometimes, rarely, I have not found that issue. The length of the tip is never an issue for me, phacofrag tip. But
Right.
regarding your vitrector, I think the one of the core messages is that once you have tried to levitate it, try to aspirate the cortex sitting over the nucleus.
Yes.
And that is why it falls.
Yes.
Because in the middle, while you are lifting it up, the
Correct.
cortex gets aspirated and
Yes.
then the vacuum is lost.
Yes.
So first, create an area where you want to, grab.
Yes, we do that
Grasp.
practically.
Yeah,
Yes.
that is a very important. Second thing that I want to contradict you is regarding the PVD induction.
Okay.
Not for the say that what purpose you serve. The only issue with me is that once you have created a big tunnel, that if you try to do a PVD, the vacuum is lost very fast, and then it is
Yes.
very difficult since you have already created a SICS tunnel to induce a PVD. That is what I am worried about, because you already have created a SICS tunnel, so it's very difficult to induce a PVD.
So basically, you are also agreeing that we need not induce the PVD, or we cannot induce,
No, I
and
feel-
just one more additional
Timing of
reason.
the induction of PVD should be done
Before the creation of the tunnel. That is
Before.
what-
Yes.
yeah,
Okay.
that is-
and that was one thing which he showed, that he kind of like levitated it. And I mean, if you do make the tunnel first and then you try to go in, then because of since the anterior and the posterior chamber are it's one compartment itself, the lens kind of tends to whirl around inside the intraocular space, and that becomes an issue. So need not open the tunnel at the first go.
Yeah.
So first you go in, try to levitate, and then possibly you can do that.
But if you have a good tunnel, a well-sealed tunnel, then it shouldn't be an issue, right?
Yeah.
And another thing is that what I have tried is, if there is a smaller piece, then I levitate it and then eat it up with a phaco.
Okay.
But
It's
then
a
we can-
smaller
yeah,
piece.
even
You
that
can-
you can
In
do
that
this,
case,
you
some
can
traction,
levitate.
some theoretical traction may still happen, because you are
No,
telling that.
after doing vitrectomy, of course.
Tried levitating.
I mean, you have done
Rather than
vitrectomy. If it is
doing a phaco-
rather than making a large tunnel and
Can I
bringing
share one my personal? I mean, that is what I feel. Somehow I feel. I mean, always the most difficult PVDs has been drop nucleus. I don't know why.
Absolutely.
Why it
That
happens?
is there. deep
Why
set
the-
eyes,
I have
Yes.
hard
spent, sometimes I
cataracts,
spent
and
even
there is
till
no
half an
PVD.
hour just trying
And
to.
remember, these
So,
are the
but the-
eyes the IOL person have sent
Why
us
it
with the
happens, I don't know.
potential
But the
of
question is, do you
6669.
really need to induce a PVD in these cases?
See, theoretically it requires.
If you've removed all the tractions, if you've done a good core
Theoretically, you don't-
vitrectomy,
I have
Because there is a concept right now of limited vitrectomy. A lot
Yeah,
of things have
that's fine.
evolved.
Yes.
But theoretically, once you go inside, you want to
you
do
want
the
to,
PVD.
no, as VR
No,
surgeons,
but
you would want
sometimes
to.
we end up in creating some micro holes during PVT induction also. That is, but there is no RCT to, even for SFIL also, SFIL with or without induction of PVT, the occurrence of RD, there is no RCT. We are just
There is
retrospective
one
data
more
only.
contradiction to your case because many a times you will get such cases that in cases of any, if you feel that there is a compromised cornea, you should
Yes.
not do this.
Yes, yes. That's why I have told it as disadvantage, limitations. Correct. I agree.
Thank you so much, Dr.
Thank you.
Chitranjan.
Thank you. Nice discussion.